Welcome, everyone. Thank you for joining the ATS ENDELIG webinar. Today, we'll be talking about non-invasive lung function assessment in preterm infants, advances in electrical impedance tomography and oscillometry. We have three excellent speakers, both from neonatology and pediatric pulmonology, to help us guide through today's webinar. Myself and Dr. Popova will be moderating this session. Please feel free to put your questions in the Q&A box, which will show up on the bottom panel of your Zoom screen. Our goal is to have all the three presenters present their talks and then present the questions to them at the end, like a panel, so that they can answer those questions. So feel free to put your questions in the Q&A box. So without further delay, it's my pleasure to introduce our first speaker, Dr. Katelyn Enzer. She will be talking on electrical impedance tomography at the bedside and research for BPD. Dr. Enzer is an assistant professor of pediatrics and a pediatric pulmonologist at the University of Colorado, where she leads the PEDAL team, which stands for Pulmonary Experts for Tiny Airways and Lungs, caring for infants with complex neonatal lung disease. Her clinical and research programs span longitudinal follow-up of preterm infants, characterization of ventilation and perfusion heterogeneity using EIT, at the interface of diseases like BPD and pulmonary hypertension. Dr. Enzer.
Thank you so much for that introduction, and I'm really excited to be here with you all today. So I will be talking about, just go back to the beginning here. EIT at the bedside and research for BPD. These are my disclosures. And I'm going to do an overview of the basic principles of EIT, how it works, and how to perform a study to start. Then talk a little bit about what we're doing to use EIT clinically here in preterm infants in Colorado, and then talk about my research and future directions. So for those of you who are not familiar with electrical impedance tomography, or EIT, it's an imaging technique that is non-invasive, radiation-free, portable, and done in real time. And all of these features make it really ideally suited for pediatric populations, but in particular for infants who are so sensitive to the damaging effects of ionizing radiation and can be sometimes too sick or too delicate to move down to radiology for other imaging studies. So we'll talk about the steps for performing an EIT study. And first, you'll need to place the electrodes circumferentially around your patient's chest. Typically, an adhesive belt with embedded electrodes can be applied to the baby's chest, and some EIT systems may also require a ground electrode. This means that if your patient has a chest tube dressing, a sternotomy wound, or really anything that prohibits the placement of adhesive around the chest, that they can't have an EIT study performed. And as I'll talk about, because of the electrical current that runs through a band, that any electrically active implant like a pacemaker would also be a contraindication to EIT. Here are some pictures of commercially available EIT belts you may see for infants or small children. And prior studies have shown that performing EIT in preterm infants, even in the newborn period, when their skin is exquisitely delicate, is safe and well tolerated. In fact, it can be left on for several hours, which is one of the greatest strengths of EIT. During the EIT exam, very small alternating currents are applied through the electrodes, and then the resulting voltages are measured by the paired remaining electrodes. This current is well below the threshold of human skin perception, so it can't be felt during the study. And through these measured voltages, EIT calculates something called impedance, which is the resistance to the flow of current through an object. Impedance of the thorax changes depending on the relative contents of the chest, air versus tissue versus blood. And since the EIT scan rate for current devices is up to 50 times a second, that allows for frequent dynamic assessment of the chest during the entire respiratory cycle. So you can imagine the different impedance values of a normal healthy patient during tidal breathing when the air moves in and out of the chest versus a region of collapsed atelectatic lung or a pneumonia that does not change or has no variation during the respiratory cycle. While you're performing your EIT study, you need to make sure that you gather all the relevant data and see any condition that you're hoping to analyze, including different changes to ventilator support, positioning, breath holds, airway clearance, or anything else that you're hoping to capture. And importantly, EIT is not like an axial slice of the chest that we're used to looking at on CT scans because the path of an electron through the thorax is more of an arc shape. And that means EIT gives information about lung regions in more of an ellipse that include areas both above and below the belt, which in adults may not be as impactful, but in neonates can actually encompass a significant portion of the infant's lung tissue. Now moving from data collection into analysis, if you plot that change in impedance over time, you can generate waveforms for the entire thorax or just a specific region of interest in the lungs. And then those functional EIT images that you see are generated by combining a series of raw images and the corresponding EIT waveforms through mathematical equations, create these approximated anatomic images. Although it's important to note that even though they look like an anatomic representation of the infant's chest, EIT is not anatomic in the way a CT or an MRI is, because EIT measures only the change in impedance. So for example, if you had a patient with dextrocardia or congenital diaphragmatic hernia, that would not necessarily be represented on these atlas images.